this week on the BackTable Podcast.
So it's a change in what we've been doing for many, many years. But I think it's an exciting change. And this is where we should be pushing the next 10, 20 years of head and neck cancer management in terms of thinking about additional approaches to improve our perioperative management. And this first positive trial, I think, is only the beginning of that. So I think that in that sense, I'm excited about it. Secondarily, I would echo a lot of things that Dylan has said already, that the major barrier for many people is the clinical efficiency piece at the bottom. That includes the medical oncology visit, it includes the CPS testing, it includes like when you schedule surgery, in terms of the timing of that, and what do you do if you have to pivot or changing the surgical approach and all these kind of things. So I think that clinical efficiency bullet point you have there really encompasses a lot of those concepts that we've discussed. But fundamentally, it's a exciting new approach, and I'm really looking forward to seeing how people embrace this across the country and the world.
Today on BackTable, we have two colleagues here, Ravindra Uppaluri and Dylan Roden, who I'll let introduce themselves, to talk about the implementation and what it means for all of us as care providers of head and neck cancer and the recent approval of Keynote-689. So before we get into this, let's do some introductions. So Ravi, why don't you introduce yourself?
Well, thanks, Adam. Thanks for having me on this. I'm Ravindra Uppaluri. I'm the Chief of Head and Neck Surgical Oncology here at the Brigham Dana-Farber Cancer Center here in Boston, Massachusetts.
Hey, good afternoon, everybody. I'm Dylan Roden. I am an associate professor at Rutgers, New Jersey Medical School. And here at Rutgers, we were one of the higher enrolling sites for the Keynote-689 study in terms of the North American, specifically United States sites. Thank you.
Yeah, for sure. And I'm Adam Luginbuhl. I'm one of the physicians at Thomas Jefferson University. I've had a keen interest in the neoadjuvant phase of treatment over the past 8 to 10 years here, and thrilled to have this to a point now where we can talk about it from an FDA approval standpoint. And we're thrilled to have Dr. Uppaluri here. And maybe to start, why don't you give us a little bit of rundown just about what is Keynote-689? I'm not sure, in your introduction, you mentioned that you led this trial with a number of other colleagues. So go ahead and tell us a little bit about the trial itself and what it led to.
Well, thanks, Adam, again. So 689 is the first international phase 3 trial that tested the addition of neoadjuvant and adjuvant immunotherapy, specifically pembrolizumab, to the surgical approach for locally advanced resectable head and neck cancer patients. So as many of you know, locally advanced head and neck cancer patients, many of them undergo surgery as an upfront treatment. And for over 20, 30 years now, the standard has been surgical resection, ideally to negative margins, followed by adjuvant therapy that's dictated by the pathology. And the last phase 3 trial we had in this setting for the adjuvant setting were the 2004 studies published in the New England Journal of Medicine that tested the addition of cisplatin to adjuvant radiation. And really that was the last sort of change in the field, which showed that adding cisplatin for high-risk patients, that is those patients with positive margins and external extension, had slightly improved outcomes compared to radiation alone. So with this background, we and many others, including Adam, your group at Jefferson and other groups, have tested this idea of introducing perioperative immunotherapy to try to improve what we've been doing for many, many years. And those early studies that were provided a signal, the limitation being they were all sort of single-arm trials, suggested that perioperative immunotherapy may be a way to change our current paradigm of surgery followed by adjuvant therapy. So with that background, we, working with Merck, developed the 689 clinical trial protocol, which tested addition of 2 doses of neoadjuvant pembrolizumab prior to surgery for patients with locally advanced neck cancer, followed by adjuvant pembrolizumab added with concurrent with radiation or radiation plus chemotherapy plus maintenance pembrolizumab. And the results of this trial, which enrolled over 700 patients internationally, were really exciting. I presented them at the AACR meeting earlier this year, and this showed that for the first time, this regimen was able to improve event-free survival, that is, recurrence, death from the time of randomization in patients who received the perioperative pembrolizumab compared to standard of care patients. So these findings have led to publication and FDA approval. And I think what we're really going to focus on today is an exciting discussion about how we're going to implement this in our practice.
Yeah, thanks. It was exciting to be there at the AACR meeting and see that presentation. And I just reflecting, I think in our row, there was probably 10 of us have been awaiting that moment. And it's probably the first time in my career where I've actually been in a room where data was presented that was, we all knew would be transformative for our field. And as an academic, it's an exciting moment to be a part of something like this. So kudos to you on that great presentation and to the AACR for bringing that to the table. And then again at ASCO again. So this whole implementation thing, I've had, I don't know, have you guys had multiple conversations with folks since the reveal about how this actually gets put into practice? Have you had some dialogue?
Yeah, I mean, I would say that a lot of people were very excited with the results. I think a lot of people were thinking that this could be a positive trial. But when we finally saw some of the mature data, everybody was very excited to begin to implement it. But I do think that many people still have questions about what are the best patients to implement it for, and how do we go about rolling it out into more of our standard practice.
Thank you, Ravi, for that introduction about the trial itself that led to the FDA approval. Our focus here today really is to bring ourselves towards the practical and to spend time talking about some of the challenges we face as we implement this into our real-world clinics. And so, again, I do want to encourage residents, medical students that might be listening to this, to encourage your faculty back home to do a journal club on this paper. But for the sake of our time today, let's jump right into the implementation of this. So we're going to use this screen here in detail. I want to first start here with this first area that we need to be focusing on, and that's the moment of diagnosis to the point of giving your first dose of pembrolizumab. As you can see in this period of time, there's two things that we need to focus on: one, CPS score, and two, the dosing delivery. So I'm going to start first with you, Dylan. If you don't mind, just tell us a little bit about why the CPS score is critical. What does that mean?
Sure. Yeah, the combined CPS, or combined positive score, is basically a measure of an immunotherapy score, or it's a ratio of the cells that are expressing PD-L1 in the tumor microenvironment. And so a higher score generally is predictive of a better response to immunotherapy treatment, although obviously there's no perfect correlation, but there is a correlation nonetheless. And so specifically for the Keynote-689 study, as it relates to the FDA approval, the neoadjuvant and adjuvant immunotherapy has been approved for the CPS score greater than or equal to 1 population, which is the majority of our mucosal head and neck squamous cell cancer patients. But the CPS score should be tested for in order to assess if a patient is eligible for the neoadjuvant immunotherapy.
Okay. And because this is part of the FDA approval, Ravi, is it critical that we have this score before we try to get drug for these patients and put them on this paradigm?
Yeah, Adam, I think it is. And so it's not currently in our workflow. So the real discussion is how to make this happen. As Dylan said, the majority of patients, 95% of the patients in the trial were positive for CPS 1 or greater. So that's encouraging for our patients that most of them will qualify for that. Having said that, you want to really not treat the patients who are less than 1 because of the FDA indication. So with that consideration, how do we make this efficient? So CPS testing has been traditionally done in most institutions at outside facilities. And so it's a send-out test, and that introduces this time window piece. And so practically speaking, how can we make that efficient? In the recurrent metastatic setting, there's time, and here there's more time pressure to get it done. So obviously getting the initial biopsy sent out as quick as possible. And some institutions are starting to do it as a reflex test. So that as soon as a biopsy sent for diagnosis, they're getting CPS testing. So that's one possible way we can accelerate this definition of who may qualify for the trial. In a situation where a patient comes in to see you and an outside biopsy has been done, what we've occasionally done is repeat the biopsy if it's feasible to do and it's tolerable for the patient. If it's a local oral cavity tongue lesion, for example, you can rebiopsy it and expedite the CPS testing in that way. So there's a couple different ways to think about it. One is potentially defining reflex testing for CPS1 for CPS testing, which is, I think, being talked about, but it's not currently done nationally for all patients with locally advanced disease. And second, considering how to expedite if you already had a biopsy, how to expedite that testing.
Essentially, we're looking at a really tight window from diagnosis when they show up in your office as a clinician to the point of getting drug, we have two things we got to achieve. One, we got to get the CPS score, which we just talked about, and some of the thoughts you shared behind that. Secondarily, we got to get them into our colleague in medical oncology. Sometimes those visits can be lengthened and be inappropriately long. And so if you're looking to implement this, it can be the normal workflow of, yes, see MedOnc when next available. There has to be some degree of attention to the detail of like within the week, because everything, you have to then get pre-approval. That pre-approval then has to get scheduled for a chair. And before you know it, you're 3 weeks out. You've lost a critical window of time. And so I'm just going to encourage folks that are starting to do this to really have an attention to that with their medical oncology team and how to navigate that. I really encourage nurse navigation, helping with that.
Yeah, just to emphasize that again, Adam, I think we know that managing these locally advanced head and neck cancer patients, it takes a village. And so having that sort of discussion with our colleagues is so critical, and we're trying to change the culture here, how we do this. And so that piece, by getting our MedOncs involved, is I can't agree with you more on that. So
yeah. So as the trial and the FDA approval outlines, the pembrolizumab 200 milligrams given once every 3 weeks. So this first 3 weeks, some of my discussions, probably the most dominant discussion I've had with folks that are trying to be early adopters of this, has centered around the concern about, I've heard phrases like lose the patient, not sure where they are, disease progression, things of just an anxiousness that we might have as a clinician. And so we at Jefferson at least have developed this thing where after they get scheduled for their chair to get their pembro, there's an automatic reflexive appointment made for the surgeon, essentially mid-morning, for a clinical evaluation with a scan right beforehand. That allows us to keep a tight, kind of a very involved surgical team, and not just sending off for 6 weeks or 8 weeks. And then when they come back, you're wondering, where do I put this patient? What's going on? So a really tight window on that. What we then do is we essentially schedule that same day, a 1 p.m. chair for that patient to get their second dose of pembro. And so that allows for that same day for us to see, confirm, and then move on to treatment. And then 3 weeks again, this is the paradigm as outlined by the trial, and then surgical date, they're scheduled after that. This also allows for surgical counseling, so you can talk to the patient about the operation you're planning. And it also allows to make sure the patient is going the right direction. And rare occasions we can have progression. We'll talk a little bit about that. It's not common, but it's not impossible. And having that moment where you can check in on the patient, check in on the tumor, and then pivot if necessary is a critical step.
just one comment going back, Adam.
Yeah.
With respect to the second dose, the timing of surgery, while you have it listed as 3 weeks there, I think that from our surgical scheduling standpoint, that's not necessarily going to work out exactly be 3 weeks. So I've been asked that question: how much long do you need to wait? I think we still haven't defined this officially, but I can just tell you that my sense is that 1 to 3 weeks is fine. So as early as 1 week after the second dose is okay, I think. So again, we haven't tested that experimentally, but from a surgical standpoint and practically speaking, to get the date exactly at 3 weeks is going to be tough. So I think having some wiggle room around that is actually okay.
Yeah, so important. I think another concern I've heard is that this is totally going to disrupt our ability to schedule patients surgically. I'm a little hesitant to agree with that answer. I think that's just because we haven't had this paradigm shift into our culture yet. But once we adjust to some things, I don't think we'll manage okay. And having that knowledge, I think, is really important, that there is some wiggle room there. And then obviously adjuvant treatment, which is not the focus of this. There's a whole paradigm that we can talk about as it relates to the adjuvant side of things, which we're going to at the moment kind of just say that it's there. Don't forget about it. The trial was designed for a neoadjuvant adjuvant treatment. Let's transition a little bit to talk about some cases. Any thoughts, Dylan or Ravi, you want to share about implementation first before we go into these cases? Anything you want to bring up, or you feel like we can discuss them as we go?
Yeah, sure. I mean, I think that in terms of the appropriate cases to select, at least in the beginning, as maybe you're gathering more experience with this new paradigm, is to choose, like low to medium volume primary tumors and avoiding things that are already on the borderline of resectability. I think that allows, if there is some slight progression, that you haven't progressed from an operable situation to an inoperable situation, and also just kind of provides a little bit more wiggle room for you in terms of how the tumor may or may not respond.
Yeah, I think the other consideration is obviously there's lots of patient factors in considering these kind of trials because it doesn't require patient engagement both in the neoadjuvant and adjuvant setting. And I think we all have a sense or our sort of radar about how patients are going to act through their treatment, obviously. And so one of the key considerations here is that the trial, the 689 regimen includes this 2 doses of neoadjuvant. I know we're not going to talk a lot about it, but there's a significant adjuvant phase also. So patients really have to commit to this. I think in terms of selecting the right patients, that's a key thing to think about. Like, when you talk to the patient, it's a complete package. It's not a la carte, oh, you're going to just do this part or that part. I think it's important to pick patients also from that perspective. So there's sort of tumor characteristics, and then there's patient characteristics also that need to be considered, I would say.
Yeah. Along those lines, can you give us a little insight along that line as it relates to the intent of the trial and the intent of the indication, right? So sometimes in my mind, when I thought of neoadjuvant and adjuvant, I was thinking about cytoreduction as we often think about chemotherapy. It's a little different, like, right? We're looking at disease-free curves and looking at survival benefit. And as we know, HPV negative, advanced, locally advanced, not so hot. And so what's really the intent here as it relates to using immunotherapy?
I think, we talked briefly about chemotherapy as a cytoreductive approach. The biologic rationale for immunotherapy is that this is a priming dosing that you're doing. You're actually trying to so-called vaccinate the patient to get long-term benefit. So while we all would like to see rapid responses in that window and allow us to think about surgical reduction or altering adjuvant therapy, these kind of things, I don't think that was a primary intent of the trial. The primary goal is that there is this immunologic rationale that giving neoadjuvant immunotherapy in a previously untreated patient allows you to take advantage of an intact immune system, a large tumor burden with tumor antigens present to help vaccinate the patient, essentially to achieve long-term disease control. So Dylan already made the point, we'll talk about it in one of the cases you're going to present, is this question about there's going to be gray areas on both sides, right? A patient with this early stage, relatively earlier stage disease, should they really get this sort of intensive treatment intensification? On the other side, if you have a borderline resectable patient, are you really going to, if you think you're going to make them resectable, that's not the right approach for this. So I think that's a key thing here.
Yeah.
So there's a biologic rationale. We hope that now that once this gets implemented, we'll try to start asking those other questions that we just talked about. Can we make additional changes? Is there a response adaptive surgery possible in the future? But those are future questions, I would say.
Yeah, and I guess I would just add that in terms of the expectation of what would happen after 2 doses of the neoadjuvant immunotherapy, I mean, you can have some patients that have a miraculous response, and we'll talk about some of those cases. We can have some patients that maybe progress. But honestly, the most common situation is that there is not a very large change in visible, on your clinical exam or on radiology, there is not a significant change that's visible on those testing. But hopefully there is a significant change immunologically in the ability to prevent recurrence, as we've seen as these results, as we see in these event-free survival curves that Adam is sharing now.
Yeah, for sure. So that's a nice segue. And I think it's so critical that we just talked about this whole thing, because I don't want listeners here to be focused on what you're about to see as like our hope is that every patient is going to be a complete response. But let's talk about a few. So let's start with this first case. I put it up here. This is a female patient in her mid-50s. She's got a T2N3 disease. You can see the nodal conglomerate with some fuzzy borders here, loss of the SCM border on this video, and a lesion that's about 9.8 millimeters thick, 24 millimeters long on the lateral side of her tongue here. You can see the image here in the PET scan. So Dylan, why don't you start? What are your thoughts about this case as a potential candidate? Would you think about it in this case, or would you be hesitant, or what are your thoughts?
I think that this is a reasonable, appropriate candidate for this treatment paradigm. Primary tumor is sizable, but not enormous. I think they're probably, borderline needing a flap at this point with good response. Maybe you avoid a free flap, although that's not necessarily the goal, but I think that it is a reasonable case to put on this treatment paradigm.
All right, so we gave 2 cycles of neoadjuvant immunotherapy. Patient comes back into the office. This is the identical patient. It's almost hard to believe, but that's her clinical photograph. And ultimately, took her to the OR, did a partial glossectomy. We did not use a free flap on her. Again, I want to emphasize that our goal and intent here was not to reduce the surgical resection to a place where we did or did not. That's not the reason I bring this up is, Ravi, you can probably attest to this, is you're trying to counsel the patient, and you have to be careful that you not give a mixed signal or a wrong signal, because then they have hope for something that really is not the intent of the original trial design. This is an outcome that was favorable, but just as I think Dylan, you'd mentioned 2 seconds ago, a number of these patients, you don't see any change, but at the end of the day, we see a change in their survival curves. So thoughts, Ravi, on this case as it relates to what we see here? Would you have done a hemiglossectomy on this still and a free flap?
Yeah, this is one of those things where I get asked this question all the time is, what do you do about the resection margins if you get a response? So in our original studies, because we didn't understand how tumors respond in terms of, is there a concentric sort of reduction if you do get a response, or are you going to get a reduction with sort of islands of satellites of tumor left behind, that kind of thing. So I think by the book, I would tell you, my answer would be that the recommendation would be to resect the original margins and stick with the original surgical plan. Because the moment you go away from that, you're doing sort of response-adapted surgery, and we don't have data on that yet. Having said all that, from a surgical standpoint, we all know you palpate and you kind of resect to what you feel in the OR. So I think it's going to be a balance, and we'll really have to see how folks implement this as it gets more wider adoption, in particular with patients who get a good response. So having said that, I think by the book, I would tell you that, yes, this patient should have had the original planned surgery would have been if it was a hemiglossectomy with reconstruction, with appropriate reconstruction.
Yeah, I appreciate that. And I think that's super important on a real world counsel to the patient, right? That they don't leave their signing up for this with the intent that you wouldn't do the original operation that you intended to do. Let's transition here to a larynx cancer. So this is a patient with a clinical T3N0 anterior larynx. The erosion of the anterior inner table of the cartilage was noted by radiology, making it an advanced stage disease. As we zoom in here, you can see this tumor kind of sitting above the cords. Cords both have mobility. There's no weakness to the cords. It looks like it's probably just in the supraglottic false cord area. We ended up giving 2 doses of pembrolizumab, and this is the follow strobe here after the second dose right before surgery. And you can see a small nub in there of what may be residual, or not sure what that is, but certainly a change from pre. So I'm going to pause there and ask you guys, because this is a little bit of, I put this one on here more for a controversial question of whether this patient should have been ever offered 2 doses of pembrolizumab in the first place. Is this a good candidate, or would you say a questionable candidate? Maybe Ravi, give some thoughts on maybe your practice or how you would approach this.
Yeah, so the question is, independent of the Keynote-689 regimen, what would be the treatment approach for these patients? So this patient would be a candidate for organ-preserving approach versus a supraglottic resection. I think in our practice, many of these patients would probably undergo a non-surgical treatment up front, so they would not qualify for this. That's, again, it depends on the patient characteristics. I've had several patients come in to me and say, I don't want to get radiation, or they prefer a surgical approach. So that's when I think you'd think about potentially neoadjuvant regimen in those patients. So I think before the 689 era, I would say that this patient probably would have had non-surgical treatment. The majority of these patients that I've seen would have had that here. But I've also had patients who say, I don't want radiation, or I don't want this. And I don't promise them anything like that, but they want a primary surgical approach. And those patients, I think I would consider this kind of regimen. And obviously the cartilage erosion always kind of concerns us, and whether it's really T4 disease and the appropriate staging, that kind of thing, because that's clearly an indication for a laryngectomy. So,
yeah, that certainly factored into it. This gentleman was a lawyer and was certainly interested in all treatment options that would preserve function. But there is some risk here, right? It goes the other direction. It's something you have to take on and fully counsel the patient on. Dylan, any thoughts about what you would do in your practice as it relates to this?
Yeah, I mean, it's definitely an interesting case. I mean, I think I would agree with Ravi that most likely this patient would be recommended for non-surgical treatment with that kind of stage of disease and presentation. And, we've had mostly very good results with that approach for if the disease is limited and It's really not through and through the cartilage. But yeah, as you share here, your results are also phenomenal. So why don't we talk about that?
Yeah, I appreciate that, Dylan. And granted, obviously, at this point here, post to a supracricoid, I took him for a CO2 laser resection, took down the entire anterior portion of the supraglottis there down to the lamina, and had a nice specimen which showed all treatment effect throughout, no evidence of residual disease. He's not far enough out to comment on his long-term. He's about, I think, 9 months out at this point here with no evidence of disease and no adjuvant treatment except for pembrolizumab. So he's still on treatment for that. But long and short, I think the point I bring this up is like our practices are also varying and different in how we'd manage these, and certainly very appropriate for organ preservation. But just a thought about, as we get further and further along with potential future biomarker discovery, right now we have CPS, but let's say in 5 years now, we have a test that gives us greater indication about who's going to respond and who's not. This is an exciting potential future application for that, because certainly if we had a stronger biomarker that could give us that insight, this specific case is a home run in that regard. But not to be over enthusiastic and disingenuous, I put up here case 3. This is a T4 and 2B case. Dylan, why don't you walk us through this one?
Yeah, sure. So, I have a presentation. The patient had certainly a local regionally advanced tumor, as we'll see as we get down to the level of the larynx and hypopharynx, that this tumor extends, well outside the larynx, extralaryngeal disease through the thyroid membrane and, out into the neck pretty considerably. So the patient would have required a total laryngectomy. Based on that, or be recommended for that. But, and this patient was interested in the neoadjuvant immunotherapy approach, and we did proceed with that. But, however, unfortunately, at his follow-up scan, which it was only a couple of weeks after that first scan, you can see a very different looking picture here. I mean, it's much, much larger, significantly into the base of the tongue. It's just basically colliding into a nodal conglomerate in the neck or direct extension there. So at this point, the patient is not really in a surgically resectable type of situation. And unfortunately, despite shifting gears and going through other chemotherapy treatments, he did develop metastatic disease and never, became a surgical candidate. So this kind of highlights a rare, but another possible scenario where we have significant disease progression, and the patient obviously had a very advanced disease to start with, but potentially could have been treated surgically with a reasonable chance of a good outcome. But unfortunately, I was not able to get that surgery.
Yeah, Ravi, what are your thoughts about this first picture as it relates to high volume and proper patient selection? And this is not to beat up on Dylan. Sorry, Dylan. I'm guilty. But we're all learning about this. Some of us have seen these things and have.
Yeah, I'm very happy to share experience if it helps many other people. Yeah, definitely.
No, thanks for sharing this, Dylan. I think it's not at all. I think that's the whole point of learning, right? You kind of talk about what you learn from this kind of thing. So, look, I think there's a couple of different considerations here, Adam. First of all, going back to the regimen itself, that the key point we're trying to make here is that the surgeon involvement in that neoadjuvant phase is critical for monitoring for progression. And this is kind of a wild case, in my opinion, in terms of the trajectory of this, including after just a single dose type thing. So this suggests that there's some biology here that's just not great from any standpoint, honestly. So having said that, there's a couple different considerations. One is this point about resectability and was this patient already a little bit borderline, and should they have been thought about for non-surgical therapy anyway? So you could argue, looking at that initial scan, that hypopharyngeal disease with the extent out onto the neck, there's a high risk of positive margins there, and it's truly potentially a borderline case. I think, Dylan, you'd kind of agree with that. So that's the kind of thing we're talking about here, is that this kind of patient is probably not a great candidate for this because, number one, we don't want to assume that they're going to have any response in terms of reduction with immunotherapy, because again, that's not the intent of the trial. But second, their biology suggests some very aggressive disease, and probably should think about potentially different paradigm to try to treat this patient, whether it's with non-surgical treatment up front, chemoimmunotherapy, additional type of approaches. So yeah, I think that this case highlights concerns about progression on the neoadjuvant setting, but also this question about borderline resectable patients and how do we think about that with respect to this regimen?
Yeah, it's a humbling profession, this is for sure. And as we move in this direction, we have to be aware of what to be aware of. And I think our last 10 years have shown us a number of these cases, and it can certainly stop us in our tracks. But also, I don't think they should be the thing that prevents us from actually listening to the data, listening to that disease-free survival curve and event-free survival curves.
Just want to highlight the neoadjuvant perioperative sort of regimens that have been introduced in many different cancer types. And this is a feature that you see. There's a small percentage of patients, it's usually low single digits, who will have some sort of progression. And that's what we're looking for here, is to learn from that in the real world setting. So, but I think that people being aware of that it's really important for people to be aware of that.
Yeah, the case I've seen it in personally has been T3, almost T4 tongue cancer, and it just took off. And I think so some of those borderline, more advanced, extensive, large volume tumors are things to be careful. And as we wrap up this session, I'd like to just kind of do a little kind of overview, talk about it as you again, going back to the idea of, this maybe is not a place you've been, you're thinking about implementing. So some future directions to consider. We've covered most of these things, the monitoring of the patient. We've covered about the concern about surgery being adapted. And we're looking into that. Those questions, hopefully over the next 5 years, as we get more and more data, will become more and more clear about what to do. And the concern about pushing towards a more functional outcome and then losing on the benefit of the oncologic outcome. So I'd like to switch here just a little bit about pressures that might influence our opinion of new approaches to clinical care. I don't know, I'll ask either one of you, I'll just put a number of them up there. Any of these that strike you as something you want to comment further as reasons why folks, all of us, might be influenced on our opinion here?
One thing that kind of jumps out at me is, the tumor board, and really, you really need a big team to take care of these, any locally, regionally advanced head and neck cancer patients. And, obviously for the last several decades, we have had our treatment paradigm, which has been relatively unchanged for a long time. And there's a lot of people who are used to that and kind of set and with those referral patterns and the order of things. And this is a significant change in the approach, and there's really important to communicate with the rest of the team in order to accomplish this change in the treatment approach and paradigm. And so you definitely need a big team that's on board with this change, and everybody willing and excited to offer something that's definitely different and definitely appears to be an improvement, the first real improvement in a really long time. But you definitely need buy-in from the team. And if the whole team is not really on board, I don't think, no one can do this as an individual. So you really, in order to successfully adopt this, you really need the whole team to be on board with the change.
Thanks, Dylan. Ravi?
Yeah, I think a couple quick points. First, this is a change, right? So it's a change in what we've been doing for many, many years. But I think it's an exciting change. And this is where we should be pushing the next sort of 10, 20 years of head and neck cancer management in terms of thinking about additional approaches to improve our perioperative management. And this first positive trial, I think, is only the beginning of that. So I think that in that sense, I'm excited about it. And I would echo a lot of things that Dylan has said already, that the major barrier for many people is the clinical efficiency piece at the bottom. That includes the medical oncology visit, it includes the CPS testing, it includes like when you schedule surgery, in terms of the timing of that, and what do you do if you have to pivot to moving up the surgery or changing the surgical approach and all these kind of things. So I think that clinical efficiency bullet point you have there really encompasses a lot of those concepts that we've discussed. But fundamentally, it's a exciting new approach, and I'm really looking forward to seeing how people embrace this across the country and the world.
Yeah, for sure. Some last points we wanted to throw up here is really just practical. If you're looking to do it, this could be modified. You can screenshot this. This is kind of one of the things we're looking at implementing as we go from the right trial enrollment. When you have a trial going on, you have all types of protocols in place and folks helping, and then bringing it into real world, you kind of have to recapitulate that with your nursing staff and your own team. And so if this is of any help to you, this kind of goes through a checklist that I have our nurses give, or the residents do, prior to seeing the patient if they're locally advanced, just so that it's on our radar screen as we think about these folks, and then some things to be thought about to help efficiency at the end. As you think about implementing it, this is the last slide here as we just, again, try to go there. Maybe walk us through, again, reminding ourselves a few of these things. So, Ravi, why don't you take the first bullet point?
Yeah, as we talked about it, this is the premise of this is a focus on immunologic activity of introducing a perioperative immunotherapy. It's not cytoreductive. I'd caution people who are thinking about this a way to reduce tumor sizes, whether it's from borderline resectable or even moderately sized tumor, to tell patients that it's going to get smaller. That's not the approach here. So it's really to get that long-term benefit.
Mm-hmm. Great. And as we mentioned, these are just kind of summary points, but nothing else. Just focus on that time, right? The patient is looking to you to get started. And we have to remember that our timeline to surgery really is the definitive treatment. This is not definitive. And so we can't let that timeline go away. So again, this has been a joy to talk to both of you here over this last hour. Again, I want to reemphasize the excitement that I think Ravi just shared there about where we're at in the trajectory. And I think the trajectory is not at its peak. I think there's more to be discovered, more to be understood in this line. So any parting thoughts before we close this out?
Yeah, one last thing that I'll say is that, the patient population in a clinical trial is always a little bit different than the general patient population. And the resources that you have at your disposal for patients who are on a clinical trial is potentially, depending on your institution, a little bit different than the resources that you have for, an average patient that you're just enrolling on a new treatment. Meaning that, you have an extra research team for people on a clinical trial. They're calling the patient a little bit more, checking in, making sure that they're not missing any appointments, that they're aware about this. They know they have their scan at this time. So in patient selection for this new regimen, I do think that you need to think about that and just be aware that this is more treatment. There's no doubt about it. They're getting extra treatment before, they're getting extra treatment after, and there's just a little bit more check-ins, as we talked about, the need to see the surgeon again, kind of mid-cycle, and potentially get another scan before surgery for final surgical planning. So it is a little bit more on the patient and on the entire treatment team. And so I just want to highlight that is the reality of changing the treatment regimen a bit, and that you should be prepared for that and aware of that. And just keep that in mind when you're potentially recommending this to a patient, as not all patients are maybe capable, whether they have the help at home or just the wherewithal to be able to follow through with all those things.
Awesome. Yeah. Well, that brings to an end our time. And many thanks to you both. And I'm looking forward to continue the dialogue together. So that's a wrap.
Thank you.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.